Okay, this is going to be assessment of the trauma patient. As far as the patient is concerned, there's generally three peaks of morbidity mortality that they go through. The first one here lasts within seconds or minutes of the injury, and these are not injuries that are compatible with life. Laceration of the heart, the vena cava, the aorta, severe brain or spinal cord injuries. Few of these patients are salvageable at all. Now, the second peak that they're going to have here is within minutes or hours. So death usually occurs due to traumatic brain injuries or uncontrolled hemorrhage that needs a tourniquet, that sort of thing. And also internal bleeding, pelvic fractures, or laceration to the spleen and liver, or just multiple wounds. Now, the golden hour concept is crucial to these sorts of patients actually surviving at all. And the third peak usually occurs long after we're gone, when they're in the hospital, and they get things like infections or their organs start to fail. Now, minimizing death in the second peak, that's sort of going to be our job, and it requires a good responsive pre-hospital system so we can transport these people rapidly or get to the helicopter, whatever they kind of need. As far as the trauma system hospitals are concerned, we generally have 4 levels here in Oklahoma, but only 3 are recognized nationally. Level 1 trauma, which is just going to be OU Hospital, has a full range of specialists, hand neurosurgeons, that sort of stuff, 24/7, waiting to receive difficult trauma patients. In order to be a level 1, they have to have at least 1,200 patients a year, which is pretty easy to get for level 1 trauma here in Oklahoma. And they have to have 240 admissions with a severity score, which is made by the surgeons, which is C15. Just know that means that it's pretty serious patients. So a place like OU also has to maintain an education system. So the residents that are involved there actually have to engage in outreach and trauma research. They also have to be a referral source for the communities in the nearby regions so that doctors can actually get some advice there. Now, there's 2 level 2s. They're both in Tulsa for us. They do provide comprehensive trauma care and basically everything the level 1 has, but they don't have the sorts of education requirements that a level 1 hospital has. But they do work in collaboration with level 1 trauma centers, and they also have 24-hour availability of all those sorts of specialists that you need. Now, level 3 this would be like Norman Regional Hospital. They don't have 24-hour availability of specialists, neurosurgeons, that sort of thing, but they do have a lot of resources, and they can generally get the patient to surgery pretty quickly. Just because they're level 3 doesn't mean that they always operate at that. They might have neurosurgeon and all sorts of surgeons and orthopedists there, but they're just licensed at a level 3. But all these places maintain transfer agreements basically to OU so the patients can be seen. Now, level 4s, they're not recognized nationally by the accreditation body, which is basically the American College of Surgeons. But they do provide initial evaluation, stabilization of the patient. Mostly what they can do is just kind of give them CTs and see what the problem is and send them off. What they basically do is just delay transfer to the hospital that they need. So it's usually worse to take them to a level 4 there. I think level 4, all they have to really maintain is going to be like a nurse RN on duty. So there's one pediatric trauma center that I know. It's going to be at Children's. So Children's is technically a level 2. So anytime you have a level 1 pediatric patient that needs to be seen, generally they'll direct you to take them over to the adult side trauma, and pediatric surgeon things will come there and be there whenever you arrive if you give them enough head start. Now, when we care for the trauma patient, I'm sure you remember ABCs from EMT school. But this thing kind of goes all the way to eye, especially in the hospital. So the ABCs, airway, breathing, circulation, but you got to remember, at least for National Registry, things like disability, which is going to be your level of consciousness. Typically, we do that before we start our ABCs, and the reason for that is if they're serious enough, we need to go to CAB instead of ABC. But the level D is just there to make you remember that you need to get a level of consciousness on this patient, at least in AVPU, and generally graduate to GCS score, because that's what your actual transportation decision is based off of. Now, E is going to be exposure, but this is going to include things like making sure the truck is warm and putting a blanket on the patient. After that is going to be your vital signs, a full set of vital signs for F. Focus adjuncts and failing presence. That's mostly going to be the hospitals here, but comfort measures we can do things like pad the long board, that sort of stuff. But don't forget to get history and do your head-to-toe assessment, because those are going to be very important. And the level I is there to make sure that you remember to actually look at their back. So the first 5 letters of the mnemonic here is going to be your primary assessment, A, B, C, D, E. So all these look for potentially life-threatening injuries and actually give treatment for those injuries. So things like under disability would be things like neurotrauma. If you need to do anything there, make sure you expose so you can see if there's any life-threatening injuries. Just some of those are going to include like a pneumo or hemothorax, pericardial tamponade, and remember your Beck's triad. Flail chest, which I would suggest you actually just splint from the inside with the BBM with that, and then hemorrhage control. On the primary assessment, what you're going to do, and this is important, is anytime you actually find one of these things that's going to be life threat, you have to provide the appropriate intervention right then and there. Now, an airway is really important. I'm sure you understand this, but it's required for breathing and circulation. So if they don't have an airway, they're going to die anyway. For that reason, airway protection and assessment is going to be very important trauma patients. Patients that are at risk of actually losing an airway, if they have one at all, are going to be people with altered level of consciousness, which is basically GCS equal to or less than 8. And then people that are going to have facial fractures, neck injuries, it's very hard to maintain a good airway on them. People with C-spine fractures get nerve damage, so their diaphragm is paralyzed anyway, even if they're conscious. So some of the findings here for airway and C-spine, make sure you check to see if they're breathing. I mean, you know most of this stuff. Can they actually talk? Obviously age-appropriate pediatrics. Look for any trauma to the face that's going to compromise your airway. Substernal intercostal retractions. We discussed that. Depressed levels of consciousness where they can't control their own airways. So if they vomited, then it's going to actually clog up their airway there, and they need to be suctioned. And then things like stridor. So if there's trauma to the neck, that can cause edema to those tissues, and they're going to get stridor. And you got to hurry up and hopefully get an ET tube placed, call for additional resources for a paramedic, or get them to the hospital pretty fast, because eventually what's going to happen is they're going to be so swollen you're not going to be able to get them. And then the skin even lies here. If you walk up and you see if they're cyanotic, or if they're gray pale, if they have some weird colorations. And most of the stuff you're going to see on these lists for interventions are going to be things you've been doing since you practiced in EMT school. Jaw thrust, positioning the airway appropriately, inserting an OPA, making sure you suction. And then the thing you need to do, though, is make sure that you're thinking so you can anticipate if later on down the road you think the patient is going to be unable to maintain their own airway. And then be sure and remember to initiate your C-spine precautions. Now, as far as C-spine findings, you got to think of your MOI. Is it consistent with someone that can have a C-spine injury? Think about rollovers, that sort of thing. That's certainly consistent. an inability to move or feel their extremities, even numbness and tingling, pain on range of motion for their neck, or any step-off deformities of the neck, if they're belly breathing, because possibly what could happen is one of the branches of nerves that control the diaphragm could be paralyzed, bowel or bladder incontinence, or retention, any of your signs of neurogenic shock, priapism, low blood pressure, that sort of thing. As far as breathing goes, you got to watch for several things here as well. Be aware of neck, chest, back, even abdominal trauma that can injure the diaphragm. History of diseases like COPD, asthma, emphysema, that sort of thing, where they're already kind of on the razor's edge there and not be able to breathe normally anyway. So watch for any kind of weird things with their breathing. If it's too fast, too slow, not breathing at all, that sort of thing. Is it shallow? Is it an adequate depth? Is it weak? Is it gasping? Does it hurt to inhale? Things like severe retractions, which can happen with pneumos or flail chests. Any open or sucking chest wounds, that's definitely going to be life threat. Paradoxical chest wall movement, which is a flail segment, two or more ribs broken at two or more places, and an inability to actually speak in full sentences. So you also have to watch for SpO2s below the patient's normal baseline. In these patients, even the COPD patients that normally stay around, 91% on room air, in trauma, they're going to need more oxygen anyway, so it wouldn't be a bad idea to go ahead and put them on a cannula. So some potential stuff here. Don't forget that you can give oxygen. It's very helpful. You don't want to keep these people at 100%, but somewhere 95, 98% if you can, and titrate to effect. You know how to assist with ventilation with a BVM. That's nothing new to you. On here, cover open chest wounds with a non-occlusive. That's going to be chest wounds like this guy on the right here, because if it's a sucking chest wound, we're going to use occlusive dressings. But if it's that big, the occlusive dress is not really going to be a problem, so you're going to have to go ahead and cover that. That's a big risk for infection and some other things there. And if you need it, if someone has a pneumo, you can go ahead and ask for additional resources. As far as circulation, the normal vital signs. Watch for people that aren't, young, healthy adults with beats per minute below 60, even above 100, especially in adults that are elderly and usually aren't used to having heartbeats above 100. Now, if it's a pediatric, heart rates above 100 or below 80 in small children kind of indicate a problem with their circulation. So watch out for pulses with abnormal strength, whether they're weak and thready or if they're bounding. And you can think about head injuries with bounding and then hypovolemic shock with weak and thready pulses. So make sure you control any bleeding that's going on, especially arterial bleeding. Look at their skin. You all know this. Are they pale? Are they diaphoretic? And make sure that you keep your systolic blood pressure kind of within normal ranges if you can. So if they have something below 90, you're going to need to get some fluids there as best you can. Now, in children, don't forget the formula is 70 plus 2 times age in years for what their minimum systolic should be. So any patient that verbalizes impending doom, I tend to believe they're usually the ones that do the worst. And then people that have restlessness or anxiety, because that's usually a problem with breathing or their circulation. And then you can always check cap refill, especially on kids and elderly patients. So obviously, if they don't have a pulse, go ahead and begin CPR. Now, if a pediatric patient has things like really weak pulses or absent pulses, even if you can tell there's a heartbeat and a weak carotid pulse, if they have a pulse below 60, that's still an indication that they need to have chest compressions. It doesn't have to be to the ones that are sort of, alert with it, but the ones that are certainly out of it with a heart rate below 60, and then weak carotid pulses where you can't feel it anywhere else, they need to have chest compression. Be sure to control your external bleeding, direct pressure, and then tourniquets. Make sure the tourniquet is cranked up enough to be above what their systolic is going to be, and then you can go ahead and begin your fluid resuscitation. And our goal there is not to have them be 120 over 80. Our goal is to make sure that they're not hypotensive below 90. So something about 90 would be correct. So we move on to the disability in our mnemonic. Like I said, the reason that this is here is to make sure that you assess the neurological status of the patients. You all know if you call into OU, they're going to ask you their GCS. So any profound alterations from their normal baseline can certainly indicate significant trauma, so you have to watch for that. And if families around there, it's a good indication of this. Some negative long-term effects for that neurotrauma can be mitigated if we actually give some prompt intervention. So we got to get on the ball there and start thinking about it early. And taking them to the correct facility is certainly going to be part of that. So E at our mnemonic here is going to be exposure and environmental. You all know exposure. You use your shears and you make sure that you can see everything that's going to kill these people. So all that clothing can obscure some injuries from you, especially in blood trauma. So the environmental control and the E mnemonic here. Just remember that the patient needs to stay warm. So some of the things that put these patients at risk for hypothermia during trauma, massive blood loss is certainly going to be one. It's going to be the outside temperature or the temperature in the ambulance, either one. If you infuse large amounts of IV fluids because they're hypotensive, all those fluids are going to be room temperature, and it's going to drop their temperature quite rapidly when you put it in their veins. Anybody that has an elevated alcohol level is certainly going to be more prone to hypothermia because it does cause vasodilation. So there's also impaired temperature control in people that have shock and brain injuries from damage from the hypothalamus. If you're assisting with a paramedic and they actually use paralytics and RSI so they can get an ET tube, those patients certainly need a blanket because those paralytics block the muscles from actually moving, so there's no real heat generation. And then in your pediatric and geriatric patients, those patient populations already have a reduced ability to regulate their body temperature anyway, so they're going to be way more prone to be hypothermic. Anything from the environment, moisture, maybe it's a drowning patient, or even if they have blood on them, can cause them to be hypothermic. And then the use of paralytics, like I said, it decreases internal heat production. Any of the injuries that actually produce large amounts of bleeding, whether it's the large vessels, the vena cava, the aorta, or it's pelvic injuries or bilateral femur fracture, or laceration to the liver or spleen, we certainly can put those patients at risk for hypothermia during trauma. Now, it's real easy for these patients to get a temperature that drops below 95 degrees Fahrenheit. The things that happen when they actually get that cold because we didn't cover them with a blanket or turn off the heater, they develop acidosis from anaerobic metabolism. They'll get all sorts of hypoxia in their tissues and especially in their brain. They're going to have increased diuresis. Anytime you're cold, you actually tend to urinate more frequently. And it's actually a good thing that you do that. Unfortunately, in trauma patients, it's going to cause those people to actually lose fluid from their intravascular space because their kidneys are trying to push out so much fluid from the body because they're cold. And then there's going to be long-term effects, things like immunosuppression, which is definitely possible, and they get infections and things, and it's more opportunistic for them. And then they're going to have coagulopathies where their blood either clots too much or doesn't clot enough, and we discussed DIC before. Now, it's important to remember that your secondary assessment is not a final examination. It's a quick assessment to actually go head-to-toe to see if there's any sort of secondary injuries. And the secondary assessment actually uses the last four letters of our mnemonic FGH and I. So don't forget your history here, and then to inspect the posterior especially. And all those make up the secondary assessment. So anything that you note on the secondary assessment that's not a life threat that maybe you missed on your primary, all you do is note those, and if you have time on the way to the hospital there, that's when you would treat it. It would be things like if someone had a sucking chest wound and fracture to their forearm, you're not really going to do anything for their forearm fracture. You're way more worried about that sucking chest wound. This is going to be things that are distracting injuries, which may kind of get your attention, but you got to make sure that you look at the entire situation and see what's going on. So these injuries are prioritized for later intervention, basically. Now, even in the secondary, if you find something wrong with your A, B, or C, all you have to do is go back to your ABCs again, repeat the cycle over again, fix those problems, and then return and do another secondary session. Now, remember to get a full set of vital signs. This refers to things like maybe you got a pulse rate and respiratory rate, but you didn't get a blood pressure, that sort of thing. Just make sure you get a full set of vital signs, including a finger stick if you need it, because maybe the drop in blood sugar was the thing that made them actually have this trauma happen. And these vital signs serve as your baseline for your reassessment every 3 to 5 minutes later on these serious trauma calls. So all patients with chest trauma, by the way, need to have both a radial pulse rate documented, and you should also check an apical pulse, which we'll talk about here in a minute. But make sure anybody with chest trauma that you actually take a BP in both arms. This would be people where you find things like the bent steering wheel and that sort of stuff in trauma, or hitting the chest with the big bruising. They're at very increased risk for aortic trauma and dissection. So you need to go ahead and take BPs on both sides. Now, if there's a difference of 10 millimeters of mercury, that's actually significant. So on those, you need to make sure to check both pulses. Are they equal? And then check them at the same time, both radial pulses, so you can know. And then note that, make sure you encode with that information if you can. So this is about the apical pulse. The apical pulse comes from an area called the point of maximum impulse. So if you look at this one here with the picture of the heart, and the base of the heart is going to be up here at the top, and down here is going to be the apex. That's why they call it an apical pulse. The way you measure this is just with your stethoscope. It's basically going to be where you put V4, if you're good at actually locating your landmarks. This is going to be a central pulse. It's similar to a carotid pulse, that sort of thing. But how you're actually going to find this landmark, which is going to be the fifth intercostal space. If you actually go up here and find your sternal notch, which is going to be this area right here, and then you're going to go down and find kind of just a little bump area. It's called the angle of Louis, and you can see it again over here on this. If you actually go lateral to that, that's where you should put V2. And you can mark that out, and you find your intercostal space, and you know that all you have to do is count now until you find the fifth. And then you're going to find your mid-clavicular line. It's exactly where you're supposed to put V4. Now, on some patients, you can actually feel it in this area and feel the beat, but in most patients, you might have to move some tissue around, the things you're kind of used to, and use your stethoscope and measure it. It's supposed to be over a minute, but you kind of know how to take a pulse. It's going to be a lumped up, and then measure that here and see if there's a difference between that and the radial pulses. Now, in certain patient populations, it is going to be kind of different because they have thinner chest walls and that sort of thing. So if you actually go up to almost just one intercostal space away from where you put V5, that's going to be where you're going to find this in people that are populations aged about 4. But you can also sort of find it just lateral of the midclavicular on patients that are 4 to 6 years old. Okay, and then I inspect the posterior surface. So don't forget that 50% of the body lies, on the stretcher where you can't see it. So if you fail to log roll these patients, you can miss numerous injuries. Now, C-spine should be maintained by good technique, which you should have learned in your EMT class. But, with the back exposed, make sure you look for bruising, discoloration, which means at all possible times, if, the fire department has a flashlight, use that. It's a good tool for you. And then you palpate the vertebral bony prominences where you decap ATLS. So what we're basically doing when you go down the spine is you're feeling these bony prominences. Now, these have nothing to do with the spinal column, which is going to be housed within it. But all these bony prominences here have things like muscle attachments and ligament attachments, and then nerves coming on it and things. So if you get fractures of these things and they break off, they can impinge on some things, which is why we check it. And make sure, if the spine is clear and the patient can lie still, go ahead and remove that backboard according to your protocols. It's going to be best for the patient. This is just for your information. When you go into OU, the kind of things that they're going to actually take from the patient so they know how to treat them. I mean, of course, they're going to type in cross-match so that they can get the correct blood products that they need. They're going to do a complete blood count, which is going to be how you get your hematocrit, hemoglobin, actually how many red blood cells are left. I know they've had a lot of fluid and stuff, but we need to actually know if they're anemic or not. And then just basic metabolic panels. How much calcium, how much potassium they have, what's their glucose in their blood, and how are their kidneys functioning, because if it's shunning blood away, their kidneys aren't going to be functioning very well, so they're also going to take a UA. If you're a female, they're going to give you a pregnancy test, which is an HCG test. And then, of course, any alcohol levels or tox ratings for cocaine or other drugs, that sort of stuff. And then your clotting studies, and how low is their blood actually clotting? Do they need some fresh frozen plasma, something like that? Those are going to be a blue top tube. The others are going to be different colors of green. And then if they're actually, anaerobic metabolism, it's going to be those gray tops. So the kind of injuries that we think about with blood trauma, we went over this a little bit in class when we talked about rollover injuries on motorcycles. So the injuries on like non-motorized bicycles are going to be actually very similar to your motorcycle injuries. So the heavier kind of bikes that they have, they do tend to propel the patient over the handlebars, bilateral femur fractures, that sort of stuff, but also risk of injury to the pancreas, liver, spleen, things that bleed a lot. So they're actually more likely to be propelled over the handlebars if they have one of those lighter bikes. And then they can sustain head injuries. So you need to watch for things like broken helmets to see what the mechanism of the injury actually is. Now, for falls, we watch for things that are basically 3 times patient height. If we think about adults, it's about 20 feet. If they fall from that, that's a significant mechanism. And then about 10 feet for pediatric patients. So you have to have a high index of suspicion that there's going to be some serious injuries there. If these patients actually land on their feet, they can break their heel bones, and then all that energy is going to travel up to the lumbar spines. They're going to have wrist trauma because after they fall, they're going to fall to the ground and try and brace themselves. Now, if you land on your side, though, people generally still put up their hands to protect themselves, but it's going to be a lot more trauma to their arms, so they could have broken arms, radial fractures, that sort of thing. And as their arms buckle in their body, basically their own elbows are going to fracture their ribs or lacerate their pancreas, liver and spleen problems, and liver and spleens bleed a whole lot. Now, if they land straight on their buttocks, the energy travels all the way up as well, and they can have some significant spine injuries as well as pelvic injuries and abdominal organ injuries.